Well, welcome everyone. We're just ironing out a couple technical difficulties, so we're a couple minutes starting late. I appreciate your patience with us. I'm Tom Scholes. I'm in the Department of Pediatrics here at the University of Iowa Stead Family Children's Hospital and serve as Director of the Division of Child and Community Health, as well as the Department's Director for Community Outreach and Engagement. I'll serve as your moderator for today's session, but I want to welcome all of you to today's webinar. I think it's going to be really fabulous, and thank you all for joining in. There are a couple of housekeeping items I just want to mention to you. You may see in the right-hand side of your screen the question box. As the presentation is going along, please feel free to type questions into the question box. We'll get to as many of those as we can at the end. And also you'll see in one of the boxes there the CME instructions in the handout section. And you'll also get that information for the CME credits sent to you by email. And I also want to thank Coffee Dixon, who you'll receive that email from. She's the magician who makes all of this work, and I could not do this without her. And she is incredible, and I want to thank her publicly for all the amazing work she does. Well, without further ado, let me introduce Dr. Lisa Horowitz, who's joining us today. She's a pediatric psychologist and a senior associate scientist at the National Institute of Mental Health and NIMH at the National Institutes of Health. Dr. Horowitz received her doctorate in clinical psychology from George Washington University in Washington, D.C., and completed her public health service research fellowship at Harvard Medical School and obtained a master's in public health at the Harvard School of Public Health. The major focus of Dr. Horowitz's research has been in the area of suicide prevention in the medical setting. She is lead PI on 5 NIMH suicide prevention protocols that involve validating and implementing tools for clinicians, such as the Ask Suicide Screening Questions, the ASQ. She's also one of the co-authors of the Blueprint for Youth Suicide Prevention, recently released by the American Academy of Pediatrics this past March. Dr. Horowitz is collaborating with hospitals and outpatient clinics around the country, assisting with implementation of suicide risk screening and management of patients who screen positive using the ASQ toolkit and clinical pathways. And it's with great pleasure, Dr. Horowitz, that I'll turn the virtual mic over to you, and just really looking forward to a fabulous gathering and set of information over this next hour. So thank you.
Great, thank you so much. And it's such a privilege to be here and presenting to you all who are on the front lines and really could make a difference in youth suicide. So because I work for the government, I need to put this slide up. That is NIH, that's the campus that I'm working on. And I have no financial conflicts to disclose. So if I were there in person, I would ask for a show of hands for anyone who's been touched by suicide, and either professionally or personally, and inevitably almost every hand in the audience would go up, and that's because suicide, although a relatively rare event, just has endless ripple effects and has touched almost everybody. So it's a major public health problem. So today, I'm going to talk a little bit, I'm going to give you a little brief youth suicide epidemiology, and then I want to train you to conduct universal suicide risk screening because we believe medical settings are a good place. And the best way to do this is to ask directly using validated tools. And I'm going to show you how that, we're only going to really focus on the screening part, but I'm going to show you how that fits into the clinical pathway, right? Because you can't just screen kids, you have to be able to manage those people who screen positive. So we believe we came up with a feasible way to do this, and we're going to do part 1 today is going to be screening. So before I start, I wanted to put suicide into a public health problem perspective, right? So I'm going to go to 2020, and that's the most recent year we have death registry stats on. And so what's the major public health problem in 2020? No surprises, COVID-19. and 960 people died a day in 2020 from COVID, and 10 per week for young people. And then motor vehicle accidents, another really big public health problem, over 43,000 deaths, 118 deaths a day, and 20 deaths a day from young people. And you might be surprised to see that what is even more common than motor vehicle accidents is suicide. So over 46,000 deaths in this country, 126 deaths a day, and 18 deaths a day for young people. So what do we do from a public health perspective? Well, for COVID, there was a lot of public service announcements about wearing a mask and distancing and getting a vaccine. And what this did was it decreased morbidity and mortality from COVID-19. For motor vehicle accidents, well, fasten your seatbelt used to be a public service announcement, and then it became a law, and kids need to take driver's ed before they get a license, and there's drinking and driving laws, and all this reduced morbidity and mortality from motor vehicle accidents. Now, what do we do for suicide? Well, if I put up this sign, a lot of you probably aren't familiar with it. This is the Suicide Prevention Lifeline. And mental health problems as public health problems are still so stigmatized, and especially suicide. So we have a lot to do from a public health perspective. And I just wanted to show you that motor vehicle accidents and death by suicide are almost equivalent for young people. So this is the suicide rate for 10 to 24-year-olds over time. We had a little dip in 2019, and then unfortunately it continued to increase. But if you look at total deaths for young people, you might be surprised. And young people aren't supposed to die, right? They're growing up. They're supposed to grow up to live long, healthy lives. 17% of our young person's deaths in this country was from something that's potentially preventable, suicide. And you can only imagine if 17% of the deaths were from like an infectious disease or something like that. But we still have such a long way to go here. So I wanted to show you where Iowa was. The suicide rate varies by state, and you can see Alaska and Montana have the highest suicide rates, and Connecticut and New Jersey have the lowest. And then Iowa is sort of right in between. It's the 21st lowest, which means it's the 29th highest. So it kind of fits in the middle there. But even just one suicide is one suicide too many. And there are disparities in the suicide rate. There's significant disparities among that vary by race, ethnicity, sexual orientation, gender identity, and the disparities do not stem from the identities on their own. They really reflect more systematic inequities and barriers to healthcare. So I wanted to show you, first of all, the age range. So this is a CDC slide. Yellow is 1999, green is 2017. You can see that there are fewer deaths by young people if you look at the overall death by suicide. However, I want to show you the rates and how fast they're increasing. So if you look over time, you can see these rates, and I want you to pay a special attention to preteens because that rate increased 225%. And those are just staggering increases, and this is for females. This is the suicide rates by ethnicity and race, and you can see this black line is American Indian, Alaska Native. They have the highest death rate by suicide than any other race or ethnicity. And then if we look at suicide attempts, what we see in this dotted line here that is increasing are Black youth. So Black youth now have the fastest growing rate of suicide attempts. So much so that the Congressional Black Caucus actually called an emergency task force, and they came out with the Ring the Alarm report, which really emphasized that more interventions, more research need to be done for Black youth. So what happened when COVID-19 came along in 2020? We have every reason to believe it exacerbated an already crisis level public health problem, especially for young people. This is a study just showing you the racial disparities. This is a single state, Maryland, and it looked at overall kids and adults Black residents versus white residents. The white residents had a declining suicide rate. The Black residents rate doubled. And then this is just also showing that COVID increased emergency department visits for young people with suicidal ideation, 39%. And if you look for females showing up in the emergency department, it increased 51%. It increased for males too, but the female rate just really staggering numbers here. So we believe that screening is a real, could serve for health equity. Like it could provide health equity by not saying, okay, we should screen this person or this person, but screens everybody. So in that way, it catches underserved, understudied populations, not only race, but LGBTQ plus individuals, individuals with neurodevelopmental disorders like autism, kids in the child welfare system, kids in juvenile detention centers, and in rural areas. Now, there's also a myth that younger kids don't die by suicide, but they actually think about and plan and die by suicide. And this is CDC data of the top 10 leading causes of death, and you can just see that suicide rate climbing up to number 6 for 5 to 11-year-olds. Now, again, suicide relatively rare. What's more common is suicidal behavior and suicidal ideation, right? So in the Youth Risk Behavior Survey surveys, your average high school student gets like tens of thousands of kids all over the country. And almost 9% of those kids reported attempting suicide in the past year. And almost 19% of them reported seriously considering attempting suicide. So this is your average high school student self-reporting, so we believe it's an underestimate, but just staggering statistics here. So these are the high risk factors for suicide. I'm not going to go through all of them, but the strongest one is previous attempt, right? Anyone who's tried it before is more likely to try it again. Having a mental illness puts you at higher risk. And then medical illness puts you at higher risk. That's an often overlooked risk factor. Now, most people who have these risk factors are not going to die by suicide because they're risk factors. In the same way that if you were a triage nurse in an emergency department and somebody came up to you with the risk factors for a heart attack, if they were obese and a smoker and high blood pressure, high cholesterol, family history of heart attack, if they just walked up to your triage desk, you wouldn't think they were having a heart attack. But if they came in with warning signs, right, clutching their chest in pain and sweating profusely, you would think, oh, maybe they're having a heart attack. Same thing with suicide. There's warning signs that we have to pay attention to. And the first one seems obvious, right? Talking about wanting to die. But especially with kids, we often ignore young people talking about suicide. I was part of this study looking at younger kids, and it found that 1/3 of the kids that died by suicide, these were under the age of 12, had reported this to an adult, but oftentimes it's not taken seriously. And these are some other warning signs: feeling hopeless, trapped, or like you're a burden, or the signs of depression. These are all warning signs that someone might be at imminent risk for suicide. Okay, so I just laid some very sobering statistics on you, very heavy. But this is a talk about hope in action, because, and that's what I'm hoping you get from this. So this is Merlin. He's my research assistant, Patrick's puppy. I thought we could all use a puppy right now to kind of pivot and talk about what can we do? Let these statistics be a call to action. So what can we do to decrease the suicide rate for young people? Well, there's a lot. And I am fortunate enough to work with a research team at NIH that asks, can we save lives by screening for suicide risk in medical settings? And we believe the answer is yes. So what about medical settings? First of all, suicide is rated, it's a devastating thing when it happens in the hospital. We had one here at the hospital in NIH about 16 years ago, and it actually was a catalyst for developing this suicide risk screening tool. But most hospital suicides, people think happen on the behavioral health units, but actually 1/4 of them happen in the non-behavioral health units. So they happen in the emergency room, and they happen in the ICU and the cancer units and the med-surg units and the primary care settings, outpatient departments. And so because of those data, the Joint Commission in 2016 actually issued a Sentinel event alert saying that, they recommended suicide risk screening for all patients. I mean, their national patient safety goal says behavioral health patients. How do you know someone's a behavioral health patient, and don't we all have mental health concerns? So it's really hard to know who to screen if you don't do it universally. Okay, so I just put this up to show you what are the top 5 most frequently reported sentinel events to the Joint Commission. And sentinel event is when a patient dies unexpectedly. And I wanted to show you suicide is in the top 5, and it kind of goes with fatal falls. And we all know hospitals have routinized way of screening for fall risk, right? They have a way to ask, but they don't have routinized way of screening for suicide risk. And if you look at the root cause of those sentinel events, you find that the #1 root cause is lack of assessment. So underdetection is just a really difficult problem with suicide. And if you look at death registry studies, so people who die by suicide, and this is not just adults, but kids too, have visited a healthcare provider months, sometimes weeks before they died. But they don't walk into the doctor's office and say, I'm thinking of killing myself. So if someone doesn't ask them directly, are you thinking of killing yourself? They most likely aren't going to talk about it. So the majority of attempters go unrecognized because the majority of settings don't screen for suicide risk. Now, why don't people screen for suicide risk? Well, there's a lot of different reasons, and I'm just going to touch on one of the biggest one here, and it's a common myth, and a lot of parents have it, and providers too, is that if you ask someone about suicide, you can actually put the thought into their head. Well, this is not true, and you don't have to take my word for it, because now there's at least 4 research studies showing that there's no harm in asking. And in fact, it's the opposite. The best way to keep a young person from killing themselves is to ask them directly and then listen to the answer and be the bridge to getting them help. Okay, so I'm going to pause there and show you my favorite public service announcement about suicide. It's from the Mayo Clinic. They let me use it in my presentations, but really anybody can get it. It's on YouTube. And so let's see, Ms. Dixon, if you can make sure this plays.
Yep, we see the viewer.
I have my ups and downs, just like anybody else.
Maybe more than anybody else.
I can be hard to figure out.
And I like my privacy.
I don't want you looking over my shoulder all the time.
But you know your kid better than anybody else. And if you think he's acting different than usual...
Acting really down, crying all the time for no good reason.
Or getting really mad.
Not able to sleep, or sleeping too much.
Shutting her friends out or giving her stuff away.
Acting reckless, drinking, using drugs, staying out late.
Suddenly not doing stuff he used to love.
Or doing stuff that's just not like him.
It might be nothing to worry about. It might just be high school.
Or it might be something more. He might be depressed.
Not just feeling down, really depressed.
It might be that your kid is thinking about killing himself.
It happens. More than you think. More than it should.
And people say, I had no idea.
I thought it was just a phase he was going through.
I never thought she'd do it.
I wish he'd come to me.
I wish he'd said something.
I wish I'd said something.
When it's too late. So if you think your kid's acting different, if she seems like a different person, say something.
Say, what's wrong? How can I help?
And ask straight out. Are you thinking about killing yourself?
It doesn't hurt to ask. In fact, it helps.
When people are thinking about killing themselves, they want somebody to ask.
They want somebody to care.
Maybe you're afraid you'll make it worse if you ask. Like, you'll put the idea in their head.
Believe me, it doesn't work that way.
It doesn't hurt to ask.
In fact, the best way to keep a teenager from killing herself is to ask, are you thinking about killing yourself?
And what if they say yes?
Or maybe.
Or sometimes.
Well, here's what you don't say.
That's crazy.
Don't be such a drama queen.
You're making too much of this.
That boy's not worth killing
Yourself.
over.
That's not going to solve anything.
You're just trying to get attention.
You're not going to kill yourself.
What you do say is,
I'm sorry you're feeling so bad.
How can I help?
We'll get through this together.
Let's keep you safe.
A lot of people think about killing themselves. Adults and kids.
most of them never try it, but some of them do. So if your kid says,
I'd be better off dead.
I can't live with this.
I'm gonna kill myself,
take her seriously. Find someone she can talk to about it. Someone who knows how to help.
Oh, you're muted, Dr. Horowitz.
Okay, sorry. So that video, which is always powerful, I've seen it 100 times and every time it still gets me. And it goes on, it continues, but for limited time, I wanted to stop it there. You can watch it on your own. But I stopped it at, find someone who knows how to help. So that's where you come in. You can be this bridge of someone who knows how to help. Okay, can you see my slides again if I forward? Oops, okay. Is that working?
Not yet. If you go back to the share and then your slides,
Okay.
it should recognize your slides.
Okay. Okay, can you see this?
It's
that work?
just a black, it's just showing as a black screen. Can you go back to that share, that little arrow drop down and then.
Yep, and I'm clicking my slides. How about now?
No, now I don't see that pop up here. Just let's try that again where you go to the right besides the show screen.
Yeah, does that work?
I don't see him yet. Is that
wait.
play button? Yep,
Screen.
there we go.
How about that? Does that work?
We just had him a second ago and then lost him. Can you try going back into your?
Okay, screen. How about now?
Yes.
Yes?
Yep,
Okay.
we can see him now.
I apologize.
No, that's good.
See it? That work? Okay.
Yep, we can see this slides.
All right, so asking kids about suicide is really important. How do you start that conversation in the medical setting in a research-tested, evidence-based way that's not going to overburden your busy practice? So we came up with this 3-tiered clinical pathway, and it starts with the screen, which is what we're going to train on today. And then each piece is so important, but this next step is the brief suicide safety assessment. That's what makes or breaks the screening program, because that takes what we learn in the screen and tells you what to do next with the patient. So we're going to talk about that. So what's screening? I mean, we're used to being screened for all kinds of things, right? Blood pressure, this is the NIH hospital. People get screened for COVID when they walk in. You have to be a certain height to ride a roller coaster. You get screened at the airport. So screening is, we get screened for a lot of different things. But what are the important conditions for screening in a healthcare setting? Well, so the condition has to be pretty serious. It can't be too rare or too common, right? Because then you don't need to screen for it. Early detection is critical, and it needs to have a treatment attached to it. So suicide meets all these criteria. And the tools that you screen with need to be brief, easy to use, have proven psychometrics, meaning they were tested and true positives. They're not going to give you a lot of false positives. And you need to screen high-risk population, which are young people showing up in medical settings, and they need to have been tested on the people they're being used. And then, of course, you need plans for how you're going to manage the people who screen positive. So what I want to really drive home here is the difference between screening and assessment, because these two ideas often get confused, and they're very different. So screening is a very brief way to identify individuals who need further evaluation. You're never supposed to go from a screening to a disposition, just in the same way you would never take someone's blood pressure, and if it was really high, you would, send them for open heart surgery. You just wouldn't do that. The assessment is a much more comprehensive evaluation. It confirms the risk, it guides the next step. So today we're focusing on the screening, And just keep in your mind that is not the same thing as assessing. You're just picking out, and I shouldn't say just because this is pretty important, but you're picking out kids that need to be evaluated further. So what are the valid questions you can ask kids? I'm not going to go into the details of this, but we did a research study with 3 children's hospital emergency departments in Boston, in Washington, D.C., Columbus, Ohio. And we had medical patients and patients presenting with psychiatric chief complaints. And we came up with this tool called the Ask. And the Ask goes, in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? And have you ever tried to kill yourself? If the patient says yes to any one of those, then you ask a 5th acuity question. Are you having thoughts of killing yourself right now? And so this is the Ask. I'm going to tell you how to use it, but it has been validated through research. It's been tested not only in the emergency room, but inpatient medical surgical units, outpatient primary care, specialty clinics with adults. Those are the places in green. The places in black where we have ongoing studies, and especially with the Indian Health Service, we're really excited about that because of what I told you about American Indians having the highest rate. It's been translated into over 17 languages. And there's a toolkit associated with it, which is at the bottom of this slide. So what do kids think about screening? I'm going to focus a little on outpatient because we ask this to kids in all our studies. Do you think you should be screened for suicide risk when you go to the doctor's office? Well, over 90% for the outpatient agreed they should. And what they said was it could be the only time suicide is brought up. And this one was a particularly serious positive screen. And this kid said, I would not have told anyone if no one asked me. And then, of course, 10% of the kids said they didn't think it was appropriate, or the kids are not going to be honest if you ask them. And then what did the parents think? Well, out of the survey, we surveyed the parents, and 71% thought it was a good idea, but 16% weren't sure. So the parents were, 8% said no. And what their reasons were, the ones in favor thought, the kid will be more comfortable at a doctor's office, and they might not be comfortable talking to their parents, which is sometimes true. And then some parents worried it would make their child uncomfortable, or that myth, you're going to make my child think about suicide. Okay, so let's get to the screening part of this. So the role of the screener. So who can screen for suicide risk? Anyone who's been trained can do the screening. And each setting needs to designate who's going to be screening. Now, the tool was created for nurses, for nurse technicians, for medical assistants, for medical technicians. But there are some places where the clinicians also do the screening. It's important because kids are more honest when their parents are not in the room. It's important to not ask, but tell the parent to step out. So when I usually do this training, a lot of the nurses that I've trained got worried about this part. The parent's not going to want to step out. And most of the time the parent will step out, but it's important not to ask them, do you want to step out? And what's even more important is not to ask the child. Because if you turn to the child and you say, do you want your parent to stay or step out? The child is probably going to be too uncomfortable to say step out. So we just teach that, just make it very normal. I'm just going to ask you to step out of the room for a minute. And this, by the way, is not go to the cafeteria and get lunch or go get a cup of coffee. This is a minute. I'm just going to ask you to step out of the room for a minute. And we have a script that we'll talk about in a minute where you say, if I have any concerns about your child's safety, I'm going to let you know. So that it's not a mystery. It's not like, hey, I'm going to do this secretive thing and you're going to be left out. It's step out for a moment. Then you administer the ask verbatim. You have to ask the questions as they are written. I have done trainings, and then 4 months later, I go back for the debrief, and some of the nurses will say, you know what, I didn't love the questions, so I changed them. I'm begging you not to change the questions because each one has been tested through research. And if you ask it a different way, you can either over detect or under detect. So it's really important to ask them all as they're written. And then it's important to look at the answers in real time. So we created the ask to be verbally administered, but some places, and this is not wrong, give the child a tablet and the child fills it out themselves. So the important thing with that is it needs to be looked at, right after the child does it, so that if they screen positive, they didn't just leave your waiting room. You'll be able to further evaluate them. And then it's important to report the positive findings to clinicians. So we recommend universal screening for kids 10 and above. The 10-year-olds were part of the research study. For 8 and above, if they present with behavioral health chief concerns, or if a parent is telling you they're talking about it, we say 8 and above. If they're under the age of 8, we don't really have screening tools that are valid for kids under 8. So we just look for warning signs, or if you hear a parent saying, my child's making these suicidal behaviors, then you can assess, right? There's where you go to assess, you don't screen. So here's the script while the parent is in the room. And this is a suggestion. After a while, you'll make this your own, but something brief, something like National Safety Guidelines recommend that we screen all kids for suicide risk. We ask these questions in private, so I'm going to ask you to step out of the room for a few minutes. If we have any concerns about your child's safety, we will let you know. Then you turn to the child and you say, okay, now I'm going to ask you some more questions, and you administer the ask. So here's the ask, and I will tell you that the majority of kids you screen, maybe sometimes 90%, 95% are going to look like this. They're going to say no, and that's negative. So that's 20 seconds. Almost, somewhere between 90 and 95% will be 20 seconds and you'll be done. If they say yes to any one of the questions, you ask the 5th question. So if they say no to all the questions, you don't ask the 5th question. If they say yes, you ask that 5th question, are you having thoughts of killing yourself right now? And if they say no, that's a non-acute positive screen. If they say yes, that's an acute positive screen. Right? So there's 2 ways to screen positive, non-acute and acute, and they're very different. Okay, so what's considered positive? Again, yes to 1 through 4. If a child refuses to answer your questions, we treat them like a non-acute positive. If they say yes to 1 through 4, you give that 5th question, are you having thoughts of killing yourself right now? And here's the 2 ways to screen positive. So the non-acute is yes to some of the 4 questions and a no to 5. That patient needs to be further evaluated, but it is not an emergency. The emergency is if they say yes to that 5th question. It's very rare for non-behavioral health patients to say yes, but you have to be prepared. What will you do if they do? Because it'll happen a couple times a year. Patient needs an emergent psychiatric evaluation. This patient should not be left alone. Okay, so again, let's just go over when they screen positive. Here's what should not happen. Every young person who has a thought about suicide should not be treated like an emergency, right? So I can't tell you how many places I go where if someone has a thought about suicide or screens positive, they are put in a paper gown, their phone's taken away, they're given a very costly one-to-one sitter. That it feels punitive to the patient. They may never tell anyone again that they're thinking of it, and it's such a resource waste for the hospital. It's important to know someone's thinking about suicide, but most of the time it's not an emergency. And so this clinical pathway that we're talking about is a guide to avoid unnecessary interventions. So again, when someone screens positive, you need to know, is it acute or non-acute positive? Now, the acute positive, as I told you, is the imminent risk one. That's when you use your standard of care procedure for someone at risk for suicide. Patients should not be left alone one-to-one. And any harmful items should be removed if possible. Sometimes it's not possible in a medical setting to remove all the harmful items, but someone should be there. This patient needs an urgent mental health evaluation. This is the patient that you send to the emergency room. This is the patient that you call psychiatry if you're, in an ER. You call them to come see the patient, or a crisis team. And this patient cannot leave until they're cleared for safety. This, again, I just want to emphasize, this is rare. This is not usually what happens, especially with medical patients. Now, patients presenting with behavioral health chief complaints will have a higher acute positive rate than non-behavioral health chief complaints. What do you say to that acute positive screen? You say, I'm really glad you're telling me about your thoughts. I want to keep you safe. I'm going to ask Dr. So-and-so to come speak with you, and I'm going to sit with you, or Miss Jones is going to come in and sit with you until they get here, whatever your plan is. And then you need to tell the parent, right? So you say to the parent, after screening, we have some concerns about your child's safety. We're going to follow up with the safety evaluation. I'm going to ask Dr. Jones to come speak with you, with your child and you, about next steps, so that the parent knows they're going to be included in this. This is not leaving them out. Now, more common, so I have big data, like one hospital in Dallas that had 90,000 ask encounters with kids. So overall, hospital-wide, the screen positive rate was 3%. I've seen it in some outpatient places with older kids be as high as 15%, but somewhere between 3 and 15 is probably the number that you're going to get. 99.5% of those positive screens were non-acute positive. So again, most of them are negative. Out of the positives, most of them are this. Risk is detected, but it's not an emergency. And the patient needs a brief suicide safety assessment, which is what we're going to learn about in part 2 of this. This patient can be left alone. This is not an emergency. This is things we talked about with the Joint Commission, and they're good with this because this comes from evidence. And the patient is asked to stay to complete this next step, where someone will come do a brief suicide safety assessment called BSSA. However, if the patient refuses, then you sign them out, whatever your settings against medical advice discharge is. So in the same way that if someone had a skyrocketing blood pressure and didn't want to wait for a cardiology consult or anything further, you would allow them to leave. Same thing with suicide risk. That's non-acute. So this time you say to this patient that's screen positive, these are hard things to talk about. Thank you for telling me. I'm going to share your answers with Dr. Jones or a nurse practitioner or a physician's assistant or a social worker, whoever is doing this next step in the pathway, and she will come speak with you. And then you say to the parent, you don't say to the patient or the parent, you're suicidal, or we think you're suicidal. We just say we have some concerns about your child's safety that we'd like to further evaluate, because remember, this is the non-acute positive. It's really important that they spoke up about this. I'm going to talk to, and then whoever your plan is, and they're going to further evaluate your child for safety. And then you alert the medical clinician before they examine the patient. So that, right, so if this is a well visit, this might have to come first. And then if there's time, the well visit can ensue. Documentation is really important. It's really important that you just give the facts. What did the patient do? What did they say? Patient screened positive on number 1. And you can put the question in, have you wished you were dead? It's really important not to over or under report. Because I've seen notes where people have written, patient's really suicidal, patient's not really suicidal. You don't need to judge it. You just need to do the facts of it. This is who was notified, and this was the plan. And then any interventions, if patient was acute positive, was put in a room, and so-and-so was asked to sit with the patient. Or patient was non-acute positive, Dr. Jones was alerted. So you just write down, what you did. Okay, what if the patient refuses to answer the questions? These are the non-acute positives. Do I contract with the patient for safety? We don't do contracts for safety anymore. This is where you say to a patient, promise me you won't hurt yourself. We do safety planning, but that's not the screener's job. We already talked about you're not going to put ideas into their head. Now, some people say, what if the patient doesn't seem like they're suicidal? Do I still need to ask? Yes. Every patient, every time that fits the criteria that you set needs to be asked, because you can't see suicidal risk. I can't tell you, I'm trained to assess for suicide risk, and I can't tell you how many people I thought, oh, this person doesn't have it, and they had it. So what if the patient starts talking to you as the screener about suicidal thoughts in detail? That could happen, right? And what we want you to do is to stop the patient and say, I am so glad you're talking about this. This is really important. I'm going to get someone who's trained to talk to kids about suicide to come speak with you. So you do it in a very gentle way, but we don't, especially because nurses and medical technicians and medical assistants, your time is measured in seconds. We don't want you to be the one then to sit there, hear all the stories, and have to feel like you do something about it. Your job is to screen, and then to be, thank them for talking about it and getting someone who is trained to do the brief suicide safety assessment. What if the parent refuses to leave the room? Sorry, I didn't mention that. That could happen, and that happens sometimes. You just screen in front of the parent, and it's okay, because while it's not the best, it still models for a parent how you ask a child about suicide. So it's second best. It's still okay to screen. Okay, then there's something that if a patient answers yes to question 4, past behavior, they're always going to be positive. Next time they come to your office, they're going to be positive. So this patient is always going to be positive. You don't always want them to have to go through the pathway. So if they're this way, if they're a non-acute positive, right? So next time, if your system has the ability to know that a patient, so it's September. Let's say the patient was here in April, and I have the ability to see that in my electronic health record. I can say, you were here in April. You said that you had tried to kill yourself before. Since April, have you tried to kill yourself? So that's the only time you could change the wording of this test, is you can add the language, since last visit, have you tried to kill yourself? And if they say no, and they were no to everything else, then that can be a low risk option. Okay, so we have pathways. I want to get to the questions, so I'm going to skip over this. This was just showing you, some people say, can you screen for depression with the PHQ-9 and count that as your suicide risk screen? Because it has a 9th item that says, in the past 2 weeks, how often have you been bothered by thoughts you'd be better off dead or hurting yourself some way? PHQ-9 is a great depression screen, but it is not a suicide risk screen. There's 9 studies now showing it's insufficient, because it says hurting instead of killing and has an or in it. So we did a study, these were 600 inpatient medical surgical kids, 81 screened positive for suicide risk, 103 screened positive for depression, 42 answered that item 9. But if you put this all together, had you only screened for depression, you would have missed a third of the kids at risk for suicide. And had you only used that item 9, you would have missed 56%. So it's really important not to make the patient jump through all these hoops. We stuck the ask on the bottom of the PHQ so people can screen for both depression and suicide risk. Okay, someone mentioned the blueprint for youth suicide prevention when Dr. Schultz, you mentioned that when you were announcing. I encourage you all to go to aap.org/suicide prevention. It has clinical section, a community section, and an advocacy section. All right, so I was going to just show you and reinforce. I'm going to just ask you to think of this in your head. Okay, what is this, negative, non-acute positive, or acute positive? That's obviously negative. So how about this? If the patient says yes to 1, yes to 3, and then yes to 5, what is this? That's acute positive. Okay, no to 1, 2, 3, yes to 4, no to 5, non-acute positive. No, 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 yes. Have you ever tried to kill yourself in the past? Yes to 5, what is that? That's an acute positive. And then one more, all for yes, but they say no to that question 5. What is that? That looks really serious, right? Still a non-acute positive. Okay. I think I am going to do, I'm going to play an example of screening. This is me and my research assistant, Patrick.
Okay, so I just asked you a lot of questions. And at the clinical center, we really care about your safety. So now I'm going to ask you some questions about suicide risk.
Okay.
In the past few weeks, have you wished you were dead?
No.
In the past few weeks, have you felt that you or your family would be better off if you were dead?
No.
In the past week, have you been having thoughts about killing yourself?
No.
Have you ever tried to kill yourself?
No, never.
Okay, well, thanks for answering those questions.
And then another example.
So I just asked you a lot of questions. Here at the clinical center, we're really concerned with your safety. So now I'm going to ask you some questions about suicide risk. In the past few weeks, have you wished you were dead?
No.
In the past few weeks, have you felt that you or your family would be better off if you were dead?
I mean, sometimes.
In the past week, have you been having thoughts about killing yourself?
No.
Have you ever tried to kill yourself?
Yes.
Okay, how?
I took some Tylenol that I had.
And when was that?
That was about 2 years ago.
Okay. Are you having thoughts of killing yourself right now?
No, not right now.
All right, well, I want to thank you for speaking up about things that are hard to talk about. And what I'm going to do now is get someone who's trained to talk to people about suicide risk to come talk to you.
Okay. What are we going to talk about?
So they're just going to ask you a few more questions, and they're going to check in on you about your suicidal thoughts and make sure you're safe.
Okay, that sounds fine.
Okay.
Okay.
So in summary, medical settings are a really important place to identify people at risk for suicide. It can take 20 seconds. It's important to have these guidelines in place. And I'm going to end with a quick example from an outpatient. This was started as a quality improvement project. They were just screening well visits. And a mother brought an 18-year-old with fatigue. Because it was a well visits that they were screening for, the nurse was not supposed to screen this child, but he was laying around all the time. The mother thought he had mono. The nurse just had an intuition that something wasn't right. This was a child who was very socially well connected, did well in school, was liked by their peers, and the nurse just had a bad feeling about it. So she administered the ask, and this is what it looked like. And this was one of those rare acute positives. When Dr. Abernathy, who has started off a lot of this work, he went in to talk to the child or the 18-year-old, and the 18-year-old had a scholarship to college and was caught at an underage drinking party and was arrested and was in trouble and maybe losing their scholarship. And so he had a plan to kill himself. And had this nurse not had that bad feeling and screened him, Dr. Abernathy is sure that this would have been one of the kids you read about in the newspaper the next day. So this nurse had a bad feeling, screened, and saved this child's life. He was hooked up with mental health services, and I will tell you, years later now, he's doing phenomenally. So a nurse shouldn't have to rely on their intuition, and that's why this is the best example of universal screening. I mean, I can't imagine how many nurses save the day, because nurses just save the day all the time, but you shouldn't have to do it that way. It should be systematic. Okay, so I'm going to end there. That's a picture of Dr. Abernathy, but I'm going to end it here so that we can get to questions.
No one deserves to die by suicide.
Oh, Dr. Horowitz, that was fabulous. Thank you so much. Really, really important information and really, really important guidance. and the ability to implement the screening in a primary care setting. You just really have done a wonderful job highlighting not only how to do the screen, but how to interpret the screen and the next steps. A couple questions have come through that I want to pose to you. And one, just, we hear so much about the mental health crisis that the country is in, especially during and post-pandemic. Have you noticed in any of the data that you've been collecting, whether there is that you're seeing this growth in either non-acute or acute positives over the last year or 2 years?
So I have seen an increase in positive screens for sure. I think really I think it was a problem before the pandemic, but definitely exacerbated. I can't say that I've seen the increase in acute positives. I still think that that is a relatively rare, that someone in your primary care setting who's there for a medical problem, that you'll uncover suicide risk and it would be imminent risk. I mean, if you did, then that would be fortunate because you may have just saved somebody's life. But I don't think the positive versus the acute versus non-acute ratio has changed.
Interesting. Well, I think, in a state like Iowa where, a lot of practices are in rural areas that I would call mental health deserts, unfortunately. In the situation where you get an acute positive and you don't have resources at a phone call away or even within maybe the town that you're living, what would you suggest as next steps in that situation?
Yes, and I'm so glad you asked. That's going to be in part 2, but I'm going to tell you now.
Okay. Well, I don't want to spill the beans on that.
No, I'm teasing you. No, I can't tell you how many people say that. Like, I can't screen because I'm going to uncover suicide risk, and then what am I going to do? I can't get an appointment for 6 weeks, 6 months, no access to mental health care. So there's 4 things you can do in your office. 1, safety planning. And we're going to go over this next in part 2. This is where you ask the child what are their triggers, and you come up with coping strategies, and you have a plan for the next time they're thinking. So safety planning, huge. Lethal means safety counseling. What is in the house that someone could use impulsively to harm themselves that you could safely store or get rid of? And then there's the crisis text line, the suicide lifeline. So those are 4 things you could just do in your office as a pediatrician.
Excellent.
But we'll go over those.
We'll look forward to the more detailed conversation of that next time. But thank you for the preview. That's really a good hook to get people thinking about coming back and joining us for part 2. What you mentioned about the electronic tablet screening, and when if that's the kind of workflow that a primary care provider has in their practice, do you recommend them having the child fill that out in a room where there's no one else around, or is that something you think, if they're in the waiting area, they're filling out these things, or they're in the room with their parent prior to the entry of the provider, would you have the parent leave the room for that electronic screening, or do you feel like that would be sufficiently confidential that you could do that without having a parent leave, or do it, let's say, in the waiting room or someplace like that where there's not the privacy, but there may still be enough? I don't know. What are your thoughts on that?
That's a great question, and I don't know that we know the exact answer. I know a lot of places that do have it on a tablet, do have them fill it out in the waiting room, do have it fill it out. What would be nice is if someone could say to the parent, I really want your child to fill this out by themselves, and maybe give them a little privacy while they're filling it out. If you could put that, float that idea by. But I mean, ideally, if you had the room, that would be really nice, but I think most people don't have that. So then they just hand the child the tablet and they say, please fill this out yourself, and turn to the parent and say, just give them a little privacy to do this themselves.
Yeah, that makes a lot of sense. And well, thank you. And the question has come up about, just to be clear, you're recommending that the screening be done with every child 10 to 24 with every visit. I think that came through, but
another great question. So the ask was not meant to be given more than once a month. And we recommend, there's no great answer. There's no research that answers that question. So what we recommend is no more than once a month, no less than once a year. So if you wanted to, you know, kids' lives change so quickly. Here at the clinical center and outpatient, we're going to do it quarterly. But that's because, you know, we do some of the other screens quarterly. I could see doing it month. I wouldn't do it every week. If you see a child and they come back 3 days later, would not do it. I would do it monthly at the most.
No, great. That's great guidance. Thank you. And bouncing back to the tablet question, and kind of a corollary to that is your preference to perform the screen verbally or with a tablet or some other written administration approach?
Right. So I'm smiling because my preference is to do it verbally, because I think now the kids are split on this. We did ask the kids, which way do you like it better? And half of them like it read and half of them like to do it themselves. There's some research saying people are more likely to be honest if they fill it out themselves, but you know, we called it the ask because we wanted somebody to ask this child these questions out loud. But there's plenty of places that do it where the child reads it. So my preference is to ask because you get a lot of information when you ask.
Yeah, thank you. That personal touch, I could see being a big difference, because you're, again, having a relationship that you're building as opposed to not building that relationship. So that makes a lot of sense. And well, we've hit the 1 o'clock time in a minute over. So that's I appreciate everyone's interest. I do believe the slides are available. Is that correct, Dr. Horowitz?
Yes, I will get Ms. Dixon a copy of a PDF of the slides, and we can send those around.
Well, thank you. Thank you. A couple of
If anybody has any other questions, you're welcome to email me. I'm horowitzl@mail.nih.gov, and I'm sorry I didn't leave more time for questions.
No, this was great. And the information you provided was spectacular. And I think, again, you've provided a good hook for people coming back for part 2. And we'll definitely absolutely look forward to that. And again, appreciate your time and spending this hour with us. And I appreciate everyone who has been listening in and providing such thoughtful questions. And I hope that this was a valuable session for you, and we'll look forward to catching up with everyone the next time. So thank you, everyone. Have a great rest of your afternoon, and we'll see you soon.
Great. Thanks so much for having me.